As well. He wanted to record this so we can also rewatch it and see it when we need to. So we're going to talk about cardiac assist devices again. This particular is going to be balloons and LVADs today. If it moves. Okay, what's going on here? It's frozen. Oh, there we go. Okay. It's just going to have to be quick and that said. So why do you care? Again, you may not deal with these very often, but LVADs are going to show up in your ER. They're being put in all over the country, so you're going to have to deal with them. You're going to deal with them on codes when you're responding to the floor. Specifically, you get that code to room 1002, and you got a balloon pump in place. What are you going to do? And can't you just call for help? Well, yeah, you can, but has anyone tried to get a Medtronic rep on the line at 2 in the morning? It's not so quick. If you need help right then and now, you're going to need to figure out or know what to do for the first couple steps before they're able to get there. So again, these devices are increasing in number as we don't have any more hearts to just give around. People who are end-stage cardiomyopathy, end-stage heart disease are getting these not just for getting the LVADs not just for bridge to transplant, but also definitive end stage care. So in our first case, if you're working in a local ER, a flight program has called you, you're in, say, New Mexico between, Flagstaff and, some small community hospital where they put one of these in, and you have a flight program saying they have a cardiac arrest coming into your helipad. They are a 64-year-old with an MI and they're on a balloon pump. So specifically, what are you going to do in the time? How are you going to manage that patient while this flight crew brings them to your ER, because they're the nearest ER and that's where they're going to stop, or any ground unit could stop there too along their way. So wherever you go, you may have to deal with these. Again, it may be rare, but you got to know how to treat this. Is VFib treated any differently? So basically we're going to cover a little bit about balloon pumps and how they work and operate. They're inserted percutaneously, so they are a temporary device. They're very common and have been used since the late 70s, early 80s. And we also want to cover just a little bit about how to monitor and troubleshoot the devices. There's a lot of indications for this device. The most common reason we're going to see in a hospital here when we're responding to codes is going to be these patients are cardiogenic shock from an MI. That's pretty much most of our patients we're going to see. A lot of them may be going to CABG or have just had CABG in the near future. So again, there are going to be some of those same kind of things that we learned about in the Impellas that are contraindications, specifically severe aortic regurgitation, because the balloon pump relies on that aortic valve closing in order to help generate some of its pressure. Also, you don't want to be inserting a pump in the aorta if there's known aneurysm or dissection. So again, contraindications to the device. Or severe calcific disease that's going to make it impossible to insert the sheath. So again, maybe one of those people with severe peripheral artery disease we're not going to be able to see with these. So specifically our goals when we put these devices in, or when the cardiologist puts these devices in specifically, is we want to decrease the myocardial oxygen consumption, increase the cardiac output, decrease our systolic pressure, increase during augmentation our diastolic pressure, and by doing that with that augmentation with the balloon inflates, we're actually able to increase coronary perfusion, because when do the coronaries fill? It's not during systole, it's during diastole, because they're covered by the aortic valve leaflets. So now in diastole, you're actually increasing the flow to the coronaries. And you may actually get an increase of cardiac output by about 20% from this device. So it may look intimidating, complicated, but just remember that if this device isn't here, we're going to treat the patient the same as we would any other MI or cardiogenic shock. Get them as rapidly as possible to their CABG or their angio, because that's what they need. This is just a tool, it's a bridge to help get them there, just like using vasopressors for us would be. We have the interface, our controller, and then we have the actual pump itself. This is the backside, which we're going to discuss where everything attaches to. Specifically, an important button, the on-off button, sits right here in front of the machine. Just turning it on and off becomes really important. Making sure that the helium tank is nice and open, because helium is what's used to actually drive the balloon and inflate, and then when it deflates it sucks that same helium back out. We have the EKG cable, so making sure that the patient has the EKG pads on is really important. And then there's actually an ArtLine cable that attaches from the device just right here and here. So EKG, ArtLine. Now, they are coming out with the nicer versions with fiber optics, and that goes up here. The nice thing about the fiber optics is it doesn't need to be calibrated quite as often. It has a lot less things that they would need to troubleshoot. And the final piece right here is the insertion connection port for the pump, the balloon itself. Now, this actually does not have anything that you tighten down or connect to, and the reason that is because if you lumber through and someone bumps into this, instead of pulling it out of the patient and moving the balloon device in the patient, it just yanks it out of here, and the only thing you've lost is 6 pumps of helium. It's very, very minimal. So you do that 20 times, yeah, you might have a problem. But if you just bump into that once, or when you're transferring a patient, you have to disconnect and reconnect them, it's not going to be the end of the world to disconnect here. You're going to get an alarm, but that's really easy to fix. You just put that piece right back in there. So the balloon actually inflates during diastole, so the heart has just got done squeezing and now it's relaxing and filling, and that's when the balloon kicks in and pumps up. That's your what's called diastolic augmentation. And then right before systole, it triggers off the R wave of an EKG typically. It will deflate rapidly. So it basically sucks all that helium back out, and your diastolic pressure actually falls much lower than it would without this. So now you have a low diastolic pressure that your heart has to push against. So your heart doesn't actually have to work quite as hard. So the physiologic effects, specifically you only have so much myocardial oxygen delivery your vessels can do, right? You can only maximally dilate. And when someone has an MI, now all of a sudden that supply has just dropped completely. And our demand probably is going up because it's trying to compensate, it's trying to make up for that decrease in supply. So now we have a huge mismatch, and that's where the heart's dying during an MI. Because your demand is real high, your supply is real low, and heart muscle dies. Well, if we increase the supply by diastolic augmentation when that balloon inflates, we're going to get an increased supply. And if it sucks down and basically we have a decreased afterload that we have to work against, the heart's not going to have to work as hard. Everyone remember this from med school? Specifically the arterial waveform. You see it on all your A-line tracings in the ICU. Specifically, you got systole, the dicrotic notch where the aortic valve closes, and then diastole. Well, this is kind of how the EKG plays along with that. Specifically, you have the R wave typically right before the systolic phase, because it takes milliseconds for that electrical current to actually generate the mechanical pressure. The EKG is the balloon pump's primary trigger. Again, the balloon pump will operate on its own, and even during a rest, a systole, VFib, VTAC, whatever, the balloon pump will still work just fine. And it will work just fine even if you're in a systole and you're doing compressions, because if it's in auto mode, instead of triggering off the EKG, it'll trigger off your compressions. So if you show up on the floor and someone's in a rest with one of these devices, and they're freaking out asking you what to do with them, just leave it in auto. It's going to be just fine. Because again, the balloon will trigger off its backup the arterial waveform. So if one of the leads pops off, it's not the end of the world. Just figure out where the lead popped off and put it back on, and the machine will go to its backup mode of using the arterial waveform. Again, it'll inflate right after systole and deflate right at the end. Now this is a 1 to 3 balloon augmentation, so where you're getting basically 3 beats, right? And one of them is an augmented balloon beat. So you're going to see some things. This is kind of where we do a lot of the teaching in the 1 to 2 and 1 to 3 modes, because it allows us to show more. Almost anytime we're going to take care of this, it should be in a 1 to 1, with the exception of just making sure that everything looks okay. So here's our first beat. This is completely unassisted. Unassisted systole here, and your unassisted end diastolic pressure. Then you have, again, another unassisted beat because the balloon has not inflated before that systole. So it's still unassisted systole right here, because there's no help from the balloon to make it so it doesn't have to work as hard. But now you have the balloon augmentation, where you get that extra diastolic pressure, and then following, you actually have the assisted end diastolic pressure, where you actually have a lower diastolic pressure. That just makes it so that, again, when that heart beats again, it doesn't have to work so hard. So you have your assisted systole, and then it would go back to the beginning. So typically we're going to take a 1 to 2 picture snapshot just to make sure our timing and everything looks okay, because if we don't have this, we can't see how much, the machine cannot tell you how much assist you're actually getting. So on this page, what you're going to get is your assisted systole and diastole from basically, here's your assisted and here's your assisted diastole. It'll give you that, but when you get a 1 to 2 mode, you'll actually get the unassisted numbers as well. So the unassisted should always be a higher in systole, so 104 compared to 98. That means you're getting good systolic augmentation. And then 52 is lower than 48. So again, you're getting a assist from this device. And again, after this, after we got our timing figured out, we would put back in a 1 to 1. So everyone wants to know, how are we going to troubleshoot errors, complications, and fixes? Well, thanks. The best way is to avoid any of these issues by following the checklist. There will be plenty of stuff in the checklist you can find on the document warehouse, on the protocol app for LifeLight. It just gives you that, hey, I'm making sure that all this stuff is done. But the biggest thing is making sure connections are tight where they're supposed to be, making sure everything's plugged in, making sure your helium, you have plenty of it, and documenting the depth of the catheter, because you want to know, has it moved since you got there? Has it moved, during CPR? Has it moved at any point? Because if it's moved, then we need to check and make sure that there aren't other problems going on. So big things with the device are limb ischemia, bleeding, thrombocytopenia. If the balloon is inserted, sometimes they won't be able to unfurl the full balloon. That's a cardiology problem. A balloon leak is something we need to identify, and we'll show you how today. Infection, aortic dissection, and compartment syndrome, again, stuff that we may have to deal with, just more after the code. But big things we want to do on our assessment is checking the radial pressures. So if that left pressure is weak, or we're not feeling a good radial pressure on the left compared to the right, it may not be a dissection. It may just be that that balloon is up over the subclavian. And that's one of those things that if you're finding this on your assessment, you need to call the cardiologist right away and say, hey, there's a problem. You may need to reposition this device, because we're going to have to put it in the standby mode where it's not doing anything, and we're going to have to treat that patient medically until they would make that adjustment. Insertion site bleeding, what do we do with all bleeding? We put pressure on it. You know, same kind of thing. Checking the pedal pulses. Again, most of these things are, if you're finding a discrepancy in pulses or a problem with the pulses, we just put it in standby until we figure out what the cardiologist wants to do with it, on the floor or wherever. This is going to be more of a thing, the urine output, that's going to be something more with longer transports. And specifically, if you see blood in the tubing, that's an immediate thing to stop the pump, put it in standby. I'll show you exactly where to look for that. And they need to prepare for the balloon pump to be removed, because what that means is the balloon has actually been punctured. So it can actually, you can lose helium into the bloodstream. So that's one of those immediate stoppage, and contacting the cardiologist. So if you're on the floor, you've just done CPR for 30 minutes, and all of a sudden you see blood backing up into the tubing, stop the pump, call cardiology, and let them know, hey, there's a problem. And they need to remove the machine. The other thing you may see is an augmentation alarm, especially if people are weaning on the devices. And to avoid this, we're going to take augmentation all the way to max, or 100%. You just crank it up all the way. That will avoid augmentation alarms, because one of the ways, or most of the augmentation alarms will be avoided just by doing that. Timing errors, the solution to that, pretty much, if you ever have a timing error, put it in auto. Because most of the problems come from people trying to be smart and mess with the device. Nurses, cardiologists, whoever. If people are messing with the device and trying in semi-auto or manual mode for timing, you can get these kind of errors where instead of being down at the dicrotic notch, the balloon is inflating early, still with a heart in systole. So it's not getting that perfect, augmentation. It's not taking that full work off the heart. Or it deflates after the dicrotic notch, or inflates after the dicrotic notch, and you're not getting an optimal augmentation because it's occurring late. And therefore you're not going to get that extra, diastolic assist. You're not going to get as good of a drop in your afterload, so the heart's going to have to work a little harder. Again, it's not the end of the world, but it's not ideal. So the way we make that ideal is we put the machine in auto mode. So right here, auto mode, avoid semi-auto and avoid manual, because once you hit semi-auto or manual, then you'll have to deal with EKGs, you'll have to figure out your timing of inflation and deflation. It's stuff we don't want to have to deal with. The easiest thing to do is just put it in auto and forget about it, because that will solve most of our problems. So another alarm you may get is specifically check the IABP catheter. The most common reason is it may be kinked. Just unkink it and hit restart. If it becomes disconnected, like we would do if we had to move it into any aircraft, we would have to pretty much disconnect it and then move the patient in, reconnect it to the machine, and then just press start. So if for some reason, maybe you saw blood in the line and you had to stop it during a code, and you're running a code for 22 minutes, well, if you're doing compressions, it might give you this alarm, prolonged time in standby. It may be a point where you don't want to restart the device. Just ignore it, it's okay. Just don't hit start, because if you hit start, it's going to restart the device. A rapid gas loss or leak, again, that can happen from a disconnect, but the most important thing is to check the tubing. And if there's blood in this tubing here that runs off the IABP catheter, that's a bad side. It means the balloon is probably ruptured and you can't use this device. So it means immediately putting it in standby, no longer pumping until they can replace the device. If there's no blood in the tubing, again, just reconnect it and press start. It may require a 2-second hold of the fill button for the balloon, but otherwise you can hit start from there. AFib, abnormal heart rhythms, they happen often. These patients have cardiogenic shock. Patients in cardiogenic shock have abnormal rhythms quite often. What do? Silence the alarm and treat the patient. We don't have to do very much different than our standard, ALS, algorithms of slow the heart rate down, because if their heart rate's 180, the balloon is not going to be able to properly inflate and deflate at that rate. So again, most common thing you can tell with these devices is just treat your patient. So now you're on a routine shift in your community ER hospital, and an LVAD patient with the heart button blinking comes in. He's pale, diaphoretic, can't walk, can't move, and he's really short of breath. Weather's bad, you're going to be stuck with this patient now for an hour in your small community hospital in Oregon. So again, these are really increasing in frequency. Very, very few places are doing the actual insertion of these devices. U of M around here, Cleveland Clinic, and OSU. The problem is each one inserts a different type of device oftentimes. The most common we're seeing right now is the HeartMate 2, but there's also a lot of other ones being used that make this kind of difficult. The best recommendation I can give is when you're out in the community and you know about one of these devices coming in, the best way to figure it out is talk to your local EMS crews, because oftentimes the hospital that put them in will talk to the EMS crews, but they won't talk to you. Because their assumption is, oh, they'll just take everyone straight to us, even if it's like a 4-hour transport. Well, I can tell you those EMS communities are going to say, yeah, we're not taking them. We're going to take them straight to your hospital. So being able to know what device is in place in the patients around you becomes really important, because some of the warning lights for each of these devices is slightly different. We're going to cover kind of the general terms today, but knowing what device is in really becomes important. Again, the physiology is pretty much the same as we talked about with the Impellas. But again, with most VAD cases, specifically LVADs implanted, the problem has nothing to do with the LVAD. So when you have an LVAD patient, don't immediately worry that there's a problem with the VAD. If they're coming in with a broken leg, treat the broken leg. It has nothing to do with the LVAD in most cases. But we're going to just focus on the complications, because that's what really, we want to know today. So this is your typical equipment. You actually have the implantable device. You have the drive line that runs through the patient's skin. This is where you have an opening in the patient's skin, just like if someone had the tunneled catheter for dialysis, it can get infected. You have the controller where you're going to see your watts, pulsatility index, power, flow, and then the battery, the AC adapter, and then sometimes you'll have the luxury of a monitor, but most of the time you're just going to have the controller, because people will just come in. Hopefully they'll have extra batteries. It doesn't always happen. We've had to fly someone to the nearest LVAD location where someone would have a battery because they came in with the battery light blinking and were about to die because they only had about 15 minutes left to live until that battery died. So this is one of those points where know what's going on, because if they're not coming with the battery, you need to send a police officer to that house to get the battery, or figure out a way to get the AC adapter, because that's really about the only option you're going to have in some of these places, is if you can plug them in if it's a battery problem. Especially if they're going to be stuck in your ER for any amount of time. You want to be plugged into AC. So in your assessment, the first and most important question you need to ask is this a problem with the VAD itself, or is it just like everything else, a problem with something else that the patient has going on? And immediately afterwards, just go to your CABs. Check the circulation. Do they have cap refill? Do they have a normal mental status, or at least appropriate, somewhat present mental status? Put your stethoscope on. Do your physical exam. If you hear a hum, that means the motor's working. That means the pump's working. If it's absent and you have no map is 0, you're going to have to start compressions. I know people say, oh, don't start compressions on LVADs. Well, if their map is 0 and there's no hum, it means the device is not functioning. There's only one thing you can do, and that's compressions. The way we can check the map, of course, is using Doppler, and everyone knows how you get blood pressure by palp, puff the cuff up, and then deflate it. Once you feel that first beat, which normally would be systole for someone with a normal heart function, that's actually the map for most of these cases because they usually don't have a pulse when these devices are in place. Or get your A-line set up and actually transduce that because you're going to get a much better idea of what's going on beat to beat. Making sure the battery's charged and plugged in and ensuring connections are tight. The connections being tight is kind of a theme of any VAD or assist device. And then again, check your controller screen for any alarms. So here are just some of the different models of LVADs, but your first step should be assign one of your members of your team or whoever to call the LVAD coordinator. Even if it's 2 in the morning, and they're like the Medtronic reps and take 20, 30 minutes to get back to you, you're still going to have that heads up by getting someone on board quickly. So this is the Jarvik 2000. This one's the Heartwear. This is the HeartMate 3, kind of the most common one we're seeing right now. And then this is the HeartMate 3, did I say that? HeartMate 2, HeartMate 3 device. And all function basically the same way. They have a rotary pump. They don't, typically don't have a pulse and don't have pulsatile flow and are all anticoagulated. So we run into the same problems of bleeding with these devices as we would with anyone who's anticoagulated. So the next thing we want to do, while someone's on the phone with the LVAD coordinator, is we want to check, are we dealing with a high flow or a low flow issue? The device will tell you low flow or high flow. And if we're in a low flow problem, we have to check preload. So check your IVC with your ultrasound. Look for CVP. Check on the monitor. Check your JVP. If you're identifying bleeding, stop the bleeding and then give fluid or blood as needed. So now if you have a low flow issue but you now have high preload, so your CVP is through the roof on your monitor, your IVC is super plump on your bedside echo. If you have a large LV and a large RV, basically the heart looks really big on both sides, this is likely a pump failure or the speed's too low. And most likely if you don't hear or your power's real high on the device, because the motor's trying to work but it's just not able to spin, that's really bad. You need to consider, anti-thrombotic agents to help with that. Or if you have a very small LV and a large RV, you got to consider right ventricular failure. These are all things you're going to want to be telling the LVAD coordinator when someone actually does get them on the line. So determining again whether you're low flow or if you're in high flow, the most common reason for this is infection. Again, these patients have a drive line going straight in, to the heart and the mediastinum, and if that becomes infected, now you have sepsis, and you need to consider holding any vasodilators and making sure that they're getting some vasopressors.
Sorry, back to the other section. When you said that you need to consider antithrombotic agents, I know we could be talking about a PE, but could you also, do these pumps themselves clot
They do.
the lines, or?
And we'll talk about that too as solutions.
So do they just assist the flow, or do they modulate your heart rate too?
They have nothing to do with the heart rate. They can work when the heart's not pumping at all.
Okay.
Like this completely takes over the work of the left ventricle in most cases. You can get up to 10 liters per minute of flow from these devices. So, I mean, they're fairly big, way bigger than the tiny little Impellas that we were talking about. This is like a fairly large. They actually take a core out of the tip of the left ventricle when they put these in and basically sew this in place. So it basically takes a huge amount of blood out of the heart and pumps it into the aorta. That's why you don't have any pulsatility in most cases with these devices. And again, most cases. You're going to get some who may still have a native weak pulse. So common alarms that you're going to see are just right here. Again, battery is probably the most important one. Making sure you're plugged into AC mode anytime the patient's in an ER. If they're in the waiting room, for some reason, hey, maybe they broke their leg and you think, hey, well, this person has an LVAD. Let's at least get them somewhere where they can, plug in, because they only have so much time on those batteries. High flow, low flow, power, pulsatility index, we'll discuss all these as we go. Each device has their own red hazard alarms. Again, each is a little bit different because they're all different manufacturers. So again, when you're in your community hospital, knowing when these devices are placed and what specific device is in place that you're going to have to deal with can be extremely helpful, and actually printing them up is extremely useful to know, because then you can just quickly flip, okay, I know exactly what alarm is going on here to talk and try to address. Again, if you're first time dealing with the patient, you may not have that luxury. So again, I keep saying the battery because this is probably one of the most common, most dangerous alarms, because if they're on battery mode and it runs out, the pump's just going to stop. So, bye-bye. Make sure they're plugged into AC at all times. And then switch batteries if that's not available. Again, hopefully they brought some spares. So device thrombosis is what you were talking about, Robbie. Typically on the POCUS, you're going to see a large LV and RV. You're going to get an alarm for high power, so your watts will be real high on the controller here. Immediately you want to start heparin, and depending on how bad the patient is, this may be a time where you're discussing thrombolytics. Because again, if this device fails, they're pretty much, they could be gone. Again, depends on how much native heart function they have, but again, these were placed because someone's in severe heart failure, cardiogenic shock. So now you have, again, right heart dysfunction. One problem with this may be you potentially have too high of a pump speed. You're pumping out too much from the LV, and basically the RV isn't able to keep up. You typically see a low flow alarm. You'll see that big RV and small little LV. Address and treat any of the problems you can. If they have pulmonary hypertension, treat it. If they have a PE, treat it. If they have tamponade, address that. Or if they have a pneumothorax from their years of smoking and their terrible COPD, put your decompression in either by chest tube or needle decompression, depending on what you're doing. And consider vasopressors. So, here you have a nice normal little RV, and over here it's really dilated and not squeezing. So, and a tiny little LV. So that's probably a problem with right ventricular failure. A suction event or a low flow event, again, you're going to get an alarm that says low flow and possibly low power or low pulsatility index. Assess the volume status, see how they look. Are they bleeding from anywhere? Stop that bleeding. Transfuse or give fluids as needed. And that's going to be how you're going to fix that problem. And of course, one of the most common things you're going to deal with, just in the community, this is probably something that you'll see at some point if there's an LVAD person in your community. They're going to have a driveline infection. It's pretty nasty and needs to be addressed right away. But in the meantime, if they're in septic shock, you're going to get a high flow alarm because the machine is pushing, really fast, upwards around that 10 liters per minute. And again, there's no afterload because they're all vasodilatory. So we need to throw on, some vasopressors and stop any vasodilators. So dysrhythmias, this is, a problem with these devices. And even though the left ventricle is completely supported, you also have another ventricle unless you have a biventricular device. So if that right ventricle is now fibrillating too, it's not pumping and you're not getting the preload that the device needs. So they may be able to survive a little longer than the normal person in VFib or asystole, but eventually it's going to hit up with them. So do your defibrillations. Best thing to do is just remember, don't put the device directly on the drive line or over the actual insertion site. Just modify where you're putting your pads, anterior maybe and posterior, and treat per ACLS. So something you may see is either return or worsening of function. If this person was like a young person with bad myocarditis, and they were on the transplant list, sometimes you can see a slight return of function. In that case, you may actually see a high pulsatility index, but more commonly, you're going to see a low pulsatility index where the native heart is actually giving up a little more, and the device needs to be ramped up by the team. They need to increase the rate. This is most commonly seen with, dysrhythmias or MI. So if they have another heart attack, this can make this problem worse. So again, treat the patient. If they're having a heart attack, get them to PCI, get them to the care they need. Because again, we're not going to be able to manage this. We're not going to be able to take their, device and crank up or slow the speed of these cases. So we need to treat the patient in most of these cases. So, what questions? Can you go ahead and get the lights?
How do you fit an aortic balloon pump machine on a helicopter?
It fits very easily. We actually are working with our mechanics. We used to take them, we removed the rear-facing seat, and the ratchet straps are brought in to secure the device. Front seat turns around. We used to take these. Will Cross is actually probably the biggest expert we have because we've lost so many people over the years when we used to do these. Just 5-6 years ago, we used to train all the residents how to fly with these because it was a possibility we could get them. Since we stopped doing that about 5 or 6 years ago, just that tribal knowledge got lost of how to secure it. So we're working on a policy again right now to secure the device.
You just lift it in there?
It's going to take, it will take a team. So the reason we need to know about these devices ahead of time is we want to make sure we have 3-4 people to the device to help lift it in.
How much does it actually weigh?
136 pounds. So for someone like you, CrossFitters, that's just like, no problem, right?
Which way?
So you essentially bypass the aorta with the LVAD?
You bypass the aortic valve, yes.
Okay, the aortic valve, not the, alright.
Yeah.
That answers my
You
question.
still need that aortic valve to be competent for these devices. So people with real bad aortic regurg, these devices are not going to be good for.
So we're not really able to contact a device rep in the air. Just follow these. I was just looking on the whatever.
The PPP
protocol app, yeah. But at the bottom it all says contact medical control.
Yep.
That's us.
No, that would also be the receiving physician as well. It would be the receiving physician as well.
How do we get a hold of receiving physicians?
Mark's radio is the best.
I mean, we
way.
normally can barely get a hold of PRs when we're going into some of these places.
Mark's radio is the best way to do it because you can reach. I could reach someone in Cincinnati with a Mark's radio frequency.
Right, but getting a hold of the actual provider is
Right.
another issue because cardiologists don't walk around with Mark's radios.
Right, and again, they may have to get recommendations from them.
Yeah.
But it would be the same thing if you called the device rep. I mean, you're going to have sometimes 15-20 minutes until they wake up, decide to answer their page, and call you back. So we may have some time before we have to deal with them.